Our next speaker is Dr. Ginna Laport. She is from Stanford University School of Medicine, and she's the Director of Clinical Research and Biostatistical Core of the BMT Division. She'll be speaking on optimizing timing of transplant in Hodgkin's lymphoma.
Thank you. Thank you for the meeting organizers for inviting me here to Hong Kong. So as you can see, I will be talking about optimizing timing of transplant in Hodgkin's lymphoma. Fortunately, as you've heard from Dr. Coleman, about 80 to 95% of patients with Hodgkin's lymphoma are cured for frontline therapy. However, about 15 or 20% are not cured and are considered relapsed or refractory, and autologous transplant is the standard of care. So I'll talk to you about the background of Hodgkin's lymphoma and transplantation and what are the new agents that we are using in this setting. So over the next 20 minutes, I'll talk about prognostic factors, salvage regimens, conditioning regimens, novel agents, and you've certainly heard much about brentuximab. It's also being used in the transplant setting now, and also talk one or two slides on allogeneic transplantation. So I know this is not a transplant-focused meeting, but just to give you a quick landscape on the world of transplants, it's to let you know where we are now. So this is an updated slide from our international registry in Milwaukee that shows the growth of transplant worldwide. As you can see, as far as autologous and allogeneic transplant, when you combine those two, it's roughly about 60,000 transplants are done around the world now. This peak here in autologous transplant comes from the panacea of when we were transplanting metastatic breast cancer, and as you know, because the results of phase 3 randomized trial published in 1999, this dropped off. But as you can see, since then, it is growing. This is growing for a few reasons, mainly because of broadened eligibility in the autologous setting. We can now transplant older patients, and we have better supportive care. In the allogeneic setting, this also continues to grow. This had kind of plateaued in the late 90s with the advent of TKI inhibitors, and most CML patients are not going to transplant these days because of TKI inhibitors, but this is now continuing to grow, again, because of broadened eligibility. We're now able to transplant older patients with the advent of non-myeloablative allogeneic transplantation, but we also are getting better at donor selection, and the good news is we actually have a rapidly growing donor pool thanks to the growing use of cord blood transplant and haploidentical transplantation. So this shows you the landscape of transplant in the United States. You can see multiple myeloma is still the #1 indication for transplantation, followed by non-Hodgkin's lymphoma, and here's Hodgkin's. It's the 4th leading indication of transplant in our country, mostly autologous transplantation, but a fraction do go to allogeneic transplantation. Those are mostly patients who have failed autologous transplantation. So going on to Hodgkin's, you've heard some background from Dr. Coleman. In the United States, about 8,000 cases a year are diagnosed. It presents as a bimodal peak age of incidence, younger patients and older patients, and there are 5 main subtypes, with nodule sclerosing being the most common disease or subtype, and this is the classic Reed-Sternberg cell seen in the slides of Hodgkin's patients. So as Dr. Coleman said, most patients are cured, depends on stage. Those who are stage 1, almost 100% are cured. Those who are stage 4, about 80% are cured. So for those other 15 to 20% who have relapsed or refractory disease, those people go on to autologous transplantation. Believe it or not, though, even though autologous transplantation is the standard of care for relapsed or refractory patients, there's never been a randomized trial that shows improved overall survival compared to conventional chemotherapy. However, there have been 2 randomized trials that show clearly decreased relapse and improved progression-free survival. This is one of the pivotal trials published in 1993 that showed BEAM for patients who relapsed or had refractory disease and were chemosensitive. They either went to BEAM, which is high-dose chemo, or mini-BEAM, which is conventional chemotherapy. There was an advantage for this is actually overall survival, and this is event-free survival. So this is the registry slide of about 5,000, 6,000 patients reported the registry earlier in this decade of 2000. And you can see that for patients in CR, these are the patients who benefit the most. Not in CR, but chemosensitive, you can still salvage or cure close to 50%. And those who are resistant, you can cure about 40%. You have to remember, though, that when this resistant can mean it's a very heterogeneous population. These are people who are maybe stable to disease, patients who have failed anywhere from 1 to 3 prior regimens. So I think for most patients who are resistant, even if they show stable disease, you can still cure some of those patients with autologous transplantation. But how can we best predict those patients who will benefit most from autologous transplantation. As you know, at the time of diagnosis, the IPS, or International Prognostic Factors Project, uses these factors to help for risk stratification at the time of diagnosis, but we learned that this is not good for predicting prognosis for relapse or refractory patients. Therefore, we've used retrospective analysis. This is a large analysis from the German Hodgkin's group of about 350 patients who relapsed, went on to autologous transplantation, and they looked retrospectively to see what were the factors that helped determine who would do better after autologous transplantation. They found that by multivariate analysis, these are the 3 factors that help predict who would do well after autologous transplantation at the time of relapse: the presence of anemia, having advanced stage of disease, or having a remission duration of only 12 months after frontline therapy. And depending whether you had 0 of these factors or 3 of these factors, you had all 3, these patients had the worst prognosis. There was an EBMT, or the European Bone Marrow Transplant Registry, with about 350 patients who looked at a very similar population, again, people at the time of relapse or at salvage, and then went on to autologous transplantation, looked at retrospectively to see what helped determine who did well. They also saw advanced stage disease, the use or the need for radiation therapy at the time of frontline therapy, and just like the German Hodgkin's group, remission duration at less than 12 months from frontline therapy also helped predict. So there were actually 1 or 2 other retrospective analysis that looked at these factors, and I think the most common factor that all of these studies had was remission duration less than 12 months. This is probably the most consistent predictor of who will not do that well after autologous transplantation if their first remission was less than 1 year from frontline therapy. So they've also used functional imaging to help decide or to help determine who might do well or not do well after autologous transplantation. There are a few, but this is the largest one and one of the more recent ones from the Memorial Sloan Kettering group, where they looked at 153 patients with relapsed refractory Hodgkin's lymphoma. They did functional imaging, either gallium or PET scanning, and you can see for both, this is for event-free survival, for gallium and for PET scanning, both significantly predicted who would do well at the time of, or not do well at the time of transplantation. So after they received salvage therapy with ICE, they got scanned, and if they were still gallium positive or PET positive, those people had a much higher failure rate after autologous transplantation. So you could argue, with knowing this knowledge, should these patients get more intensive therapy, something more novel, perhaps maybe consider allogeneic transplantation at some point. The next question is, what is the best salvage regimen after autologous transplantation? And I think we would all agree there's not one perfect optimal regimen. I think the most common ones used are ICE or DHAP, and you can see the overall response rates are pretty impressive and very similar, anywhere from 70 to 80%. One of the new kids on the block is bendamustine. Bendamustine is, as you know, it's been approved for some B-cell lymphomas, but it actually does have activity against Hodgkin's patients, and I myself have used this for Hodgkin's patients and people who have failed platinum regimens, and I have taken a few patients who were able to go to autologous transplantation who were platinum refractory. So I think this is actually a very promising salvage agent if they failed platinum-based therapy. What about conditioning regimens? Again, there's no perfect conditioning regimen, as there's no perfect salvage regimen. TBI-based regimens have been largely abandoned, mainly because of the higher toxicity, and there's been no survival advantage. I think it's safe to say that the BEAM regimen, BCNU, etoposide, Aracene, Melphalan, are the most commonly used, followed by the CBV regimen, which is what we use at Stanford. There are some novel regimens being used. These are small phase 2 trials, but I thought they were worth mentioning. Gemzar, or gemcitabine, has been used in the conditioning regimens. We actually have a novel regimen at Stanford. We're also using Gemzar with CBV, and there's something called BEEAM, which is actually using bendamustine in addition to the BEAM for conditioning upfront prior to autologous transplantation. The toxicity certainly has been acceptable. So how can we improve outcomes after autologous transplantation? Because obviously less than half the patients are not cured after autologous transplantation. One thing we do know when we look at their data, if a patient with Hodgkin's disease who underwent autologous transplantation is still in CR at 2 years after transplant, their 10-year overall survival is 77%. So if they can reach that important milestone of 2 years and still be in remission, they're doing fairly well. For those who are destined to relapse, those patients will relapse within 1 year. The median time to progression for those patients who do progress is about 6 months, and the median survival time from the time they relapse after autologous transplantation is roughly about 25 months, with a range of anywhere from 4 months to a few years. Those patients who relapse less than 6 months after autologous transplantation, most of them do poorly. So one way we thought we could improve outcome after autologous transplant is, the question is more better? So if one transplant is good, or 2 transplants better? There have been 2 studies on the larger side that I thought I would mention. Was the Ginna study from France with 43 patients. They only had about a 75% completion rate. That means of all the patients, of these 43 patients, only 75% actually made it to the second transplant. 25% dropped off because of toxicity or progressive disease. They found that the 2-year overall survival for those patients who made it to the second transplant was 74% versus only 40% for those patients who only made it to 1 transplant. Obviously, there's probably selection bias because the ones who did not make it to transplant probably had a very aggressive disease. The City of Hope actually had a analysis of 46 patients prospectively. 83% here made it to the second transplant. And for those people who made it to that second transplant, the 5-year progression-free and overall survival was about 49 and 54%. So this is one strategy that we are using for high-risk patients, those who have refractory disease or patients who relapse less than 12 months from frontline therapy. This has been used and certainly is promising. But of course, obviously, it's a longer treatment regimen and much more expensive and potentially more toxic. Another way to improve outcome is maintenance therapy. So this is something we're doing more in the transplant world, both in autologous and allogeneic transplantation for almost all of our diseases now. You've heard quite a bit of brentuximab. As Dr. Coleman mentioned, there is a large phase 3 randomized study now for patients who go to autologous transplantation. Half the patients go on to a placebo, and half the patients go on to brentuximab. This study was so popular, it's actually completed accrual, and so we still have to wait 1 or 2 years before we get the final analysis. But the people who were eligible for this was targeted for high-risk disease. Those are patients who had refractory disease at the time of transplant, those who had progressed within 1 year of frontline chemo, because remember, as I mentioned, if you relapse less than 12 months after frontline therapy, those patients had the worst prognosis, or patients who had extranodal disease at the time of relapse. There are some promising agents that you've heard from Dr. Kwok and Dr. Coleman. Everolimus is an mTOR inhibitor, penobinostat is an HDAC inhibitor, and also lenalidomide has been shown to have activity in Hodgkin's lymphoma. So I suspect at some point in time, these drugs will be incorporated either as salvage therapy or as part of maintenance therapy in due time. So you've heard, again, a lot about brentuximab, and you've already seen some of this data. This is from the MD Anderson and a few other centers. This is a pivotal phase 2 study. This had many patients, and these were all patients who relapsed after autologous transplantation. The overall response rate was 75% and a pretty impressive CR rate of 34%. Also, I thought this was worth mentioning. They've also found that brentuximab is actually pretty good salvage therapy for those people who fail auto and who need a bridge or some kind of drug to get them to an allogeneic transplantation. This is from Dr. Chen from the City of Hope, again, a multi-center trial, and they found that brentuximab does enable it is a pretty good bridge to take a patient and from auto to allogeneic transplantation. Again, it was a small study, only 18 patients. 17 patients had failed a prior autologous transplantation, and these are the survival curves actually from the time of transplant, not from the time of salvage. But after 1 year, it is short follow-up, the overall survival was a 100%, progression-free survival was 92%. You can see very low relapse or progression and very low non-relapse mortality. So brentuximab is actually a very good salvage regimen, even for patients who fail autologous transplantation. So what about allogeneic transplantation, Hodgkin's disease? I think most people would agree that something called a graft versus Hodgkin's disease effect does exist. It's certainly not as robust as you would see in follicular lymphoma or mantle cell lymphoma, but one does exist, and you can see this is, again, registry data of about 400 patients using allogeneic transplantation versus sibling or unrelated donor. There was a difference where patients with sibling donors tended to do better at this point in time, but you can see that about 30%, no matter which donor you use, can be cured after after allogeneic transplantation. And I don't have the breakdown of how many people here failed autologous transplantation, but it's probably safe to say well over half of these people had probably received an autologous transplantation. So you can still salvage about a third of patients after autologous failure of those people who can actually make it to the allogeneic transplantation. So I thought it was also worth showing this study. This is a study from Europe, from the European Bone Marrow Transplant Registry. It was a large study, retrospective, of almost 300 patients. So they showed the data or the outcomes of reduced intensity allo for Hodgkin's lymphoma. 80% had failed a prior auto, 25% had refractory disease, and then you can see the survival was pretty good, about 20–25%, and they found that these are strong predictive risk factors or adverse factors that help determine who would do well. If patients had a poor performance status, the older patients and those who had chemo-refractory disease obviously did not do well. For those patients who had zero adverse factors, their overall survival was almost 60%. If they had 1 to 2 of these adverse factors, this dropped to 20%. So again, I think a fraction of Hodgkin's patients who fail autologous transplantation can be salvaged with allogeneic transplantation. Obviously, you have to be selective. You have to find a donor, and they have to have a good performance status. So in summary, remission duration less than 12 months from frontline chemo is a very strong predictor of outcome for autologous transplantation. These are patients who should probably be shuttled more towards a novel agent or novel salvage regimens or a clinical trial. The optimal regimen, is not defined. Salvage therapy, ICE, GDP, which is Gemzar, Decadron Platinum, or GND, which is Gemzar, Navalbine, Decadron, the most commonly used. BEAM is the most commonly used conditioning regimen after CBV, but as I mentioned, we are incorporating more novel agents such as Gemzar and bendamustine for salvage for conditioning regimens. Brentuximab is promising for salvage, conditioning, and maintenance therapies. As you can see, the results have been so good with brentuximab. Now it's being used just about every step of the way in the treatment of Hodgkin's patients. And as I've mentioned, allogeneic transplantation can salvage about 20% of failed auto, but doesn't mean, again, there's a caveat, doesn't mean all auto patients who fail 20% will do well with allo. Of all the auto patients who failed, those who make it to allo, 20% are cured. So I just remember that statistics. So that concludes my talk, and I showed this slide yesterday, but I invite you to come visit my beautiful home at Stanford University if you're ever in Northern California. So thank you.
Please sit up here, Dr. Laport. Please stay here. Would Dr. Kwok also join us? Are there any questions for the panel?
I am Dr. Bhattacharya from India. My question to Professor Coleman. This combination of brentuximab with AVD, the analogy is obviously with R-CHOP in DLBCL. When you are using CHOP in DLBCL and when you are adding rituximab to it, there is about 20% improvement in overall survival. But when you are using brentuximab, just with ABVD in stage 1-2 Hodgkin's, there is 90–95% success rate. So what extra additionally you are gaining by adding brentuximab? Don't you think that brentuximab and AVD should be used in more aggressive Hodgkin's disease, say in stage 3 or stage 4, rather than in stage 1 or 2?
Well, some of the other panelists may want to comment as well. I could foresee the day when a patient comes into you with limited disease that, and again, this is not gold standard right now, where you do a PET scan after one cycle. If he's got limited disease and his PET scan is negative, you give him 2 more cycles of ABVD. Now, there's a little bit of difference between that and using radiation. As you saw, about a 3 to 6% difference or 7% difference. Perhaps maybe one day, again, this is for the future, you give the 3 cycles, and if you really want to confirm that you've got that 3 to 7%, give 1 or 2 doses of brentuximab vedotin. Maybe you'll get no relapses at all. When you run into toxicity with brentuximab, I would be interested to hear what the other panelists have to say. It's usually after 4 or 5 or even 6 cycles. So 1 to 2 cycles is virtually innocuous. There may be a day when we just put our thinking behind us do a PET scan after one cycle. If it's negative, oh, we'll give them a couple of cycles of brentuximab. Again, this awaits studies to be done. As of now, from the data that I showed you and the data that have been generated, I would be very comfortable stopping after 3 cycles of ABVD. If the PET scan, which was correctly read, it was negative. I think you can get away with 3 cycles in good risk stage 1 and stage 2 patients. It may turn out that in ABVD, one way of giving it is to give it with the chemo. Perhaps maybe one day for the disseminated disease, we'll give 6 cycles of ABVD and then top it off with 3 or 4 cycles of brentuximab. The only problem right now is this brentuximab is very, very, very expensive. Dr. Kwok, what do you think?
So I think your point is on spot, that the combination therapy should be considered for patients who are high risk. And that was the spirit of the phase 1 multi-center study. As you saw, many of the patients had bulky disease and high IPS scores. So I think everybody agrees with you that that's the unmet need is high-risk patients with advanced disease.
One of the things that we showed, though, both in lymphoma as well as in non-Hodgkin's lymphoma, that your international prognostic score or your international, either score, the IPI or the IPS, is not anywhere nearly as predictive as doing that PET scan after 1 or 2 cycles, because the PET scans are really a dynamic way of seeing how well your chemotherapy is doing. I agree with Dr. Kwok. I would certainly use those high risk factors, but in my opinion, the PET scan is the single most important thing you can use to predict how well they're going to do.
Thank you.
Are there any questions? Yeah.
Okay, I'm Dr. Huang. I want to ask a question, ask for Professor Laport. Yeah, in terms of indication, it seems you suggest that the patient, if the duration of CR is less than 12 months, and then you give a salvage therapy. If the patient gets CR, you can to do autologous transplantation. So my question is that. For those patients after receive the salvage therapy but not get the CR, so for those patients, can we recommend the allogeneic directly?
So I believe your question was for those patients who reach less than a CR after salvage, should those patients proceed to autologous transplant? Such as patients who are only a partial remission? Should those, is that your question?
Right. Yeah.
Yes, they should. I mean, patients, we don't require complete remission prior to proceed to transplant. They have to show at least a partial remission. And we define partial remission of at least a 50% response. We actually have taken patients with stable disease. You can still salvage probably a quarter of patients with just stable disease as long as it's not progressive. I think stable disease is more acceptable in Hodgkin's patients than non-Hodgkin's patients going on to autologous transplantation. So we don't require a CR. At least a partial response is best.
Yeah, one is that. The another is that for those patients, you are recommended to do autologous transplantation. But my question is, can we recommend this patient receive the allogeneic transplantation when they are not get complete remission?
So was your question is, should patients receive an allogeneic transplant if the remission duration was less than 12 months? Is that your question? No.
The patient was less than 12 months and get relapsed, and then so you will give the salvage therapy. Some patients get complete remission, but some patients didn't get complete remission. For those patients didn't get complete remission, can be recommended as to use the allogeneic transplantation.
Oh, so you're asking for patients who had less than a complete remission, should they go to allogeneic transplantation?
Yeah.
I would say not. As long as they have a partial remission, we're still taking them to autologous transplantation. I would say the Hodgkin's patients that we take to allogeneic transplant who didn't fail our prior auto are either patients who have bone marrow involvement where we can't clear the bone marrow, or young patients who have stable disease. I mean, as you know, it's hard to say no to a young patient who's very motivated and who has an HLA matched sibling. Sometimes we will take patients who have stable disease or maybe minorly progressive disease. We'll take them to the allogeneic transplantation. But I'd still say, as long as they have at least a partial remission, we would take them to autologous transplantation. We rarely take an Hodgkin's straight to allogeneic transplantation.
Well, as a corollary, suppose that patient had relapsed in 2 months after completing their chemotherapy. You give them reinduction therapy to get them set for the transplant. and they have stable disease. I think we do know that the PET scan is predictive, but even without the PET scan, let's say they have a partial remission and they're young, and the odds are that this patient is not going to do very well by risk factors. Why would you not take a young patient straight out to an allo? Have you looked at data at those patients who had allos without a prior auto, or do all of them have autos before you do an allo on your Hodgkin's patients?
I would say it's fair to say around the world, probably of the Hodgkin's patients who go to allo transplantation, at least 3/4 have failed a prior auto. I mean, your question is, would we ever, for someone who's had a very short remission after frontline therapy, say only 2 months, had a good response to salvage, should those patients go on to allogeneic transplantation?
Poor response to salvage. I'm saying suppose they get a partial response. Is a young, healthy guy with all the risk factors that tell you he's going to fail an auto, leaving out the possibility of adding brentuximab vedotin at the end. Would you not take him to an allo?
It's a case-by-case basis. If it's a young patient with a match sibling, we would consider an allo. I'm not sure we would do maybe with an unrelated donor. It's a case-by-case basis.
Throw a little brentuximab at him.
Right, and I think brentuximab is definitely muddying the waters of, in a good way, of what to do with these patients.
Yes, sir.
Yes.
A question for Dr. Coleman. So the data you presented was stage 1A, 2A, with the role of interim PET scans, right? How the interim PET scan, if it's unfavorable, or if it's favorable, it'll limit the use of radiation.
If they have a favorable stage 1 and stage 2, would I take them to radiation? Is that what you're saying?
No, if in a stage 1 or 2 patient, you showed the data, that was the abstract at ASH,
right,
that if the interim PET scan after 1 cycle
right,
is good, it's a favorable kind of PET scan, a good PET scan,
right,
that'll potentially eliminate radiation treatment from
that's
the
correct.
program.
Even if you look at the Canadian study comparing it with the German study, now not all of the patients were what we call high risk. They took out those patients that had some high risk features and those that had good risk features where they could compare them. Now, not every poor risk patient was included in this study, and not every very good risk patient was included. I had that sort of curve, that circle. But when they looked at that, when they made that comparison, they saw no difference. And that the chemotherapy did as well. There's a small difference. Like I say, you do get a little bit of additional benefit in terms of disease control in about 3 to 7% of patients with radiation, but you've got to counter that against the toxicity. Now, it's true that the radiotherapist will say, look, we are only using 2,000 rads now, or we're only using 3,000 rads. That's not a whole lot of radiation. And that may be so. Certainly with 4,000 rads, we see lots of complications. So the jury is still out. But I doubt if the data are going to change that much where you can show me a compelling reason for using combined modality therapy.
Very quickly, for stage 4 patients, are you using interim PET scans to guide your treatment?
Yes, I do, and I'll tell you how I do it. And again, this is a bit iconoclastic. This is not the way most people are doing it. If I get a negative PET scan in that original study that I showed you that's to be published, if my PET scan is negative after first cycle, there's no sense in doing a PET scan after the second cycle because every one of the patients that we looked at were negative. At least the Europeans did it in spite of the fact that the first one was negative. We were the American contributors. If you were negative after the first, we didn't bother with the second. If you were positive after the first, then we did one after the second. And the positive PET scan after the second cycle was more predictive than the PET scan after the first cycle. But when we look at our data, those that were positive still had a major drop in their SUV score. In those patients who get a PET scan after 1 cycle, or even after 2 cycles, if that SUV score drops by 1/3, and some of these data are now being checked at, the overwhelming odds is that patient has inherent drug resistance, and you ought to do something different. My only question is doing something different really going to work? Well, now with brentuximab, the answer may be yes, but that, in my opinion, that's inherent drug resistance, and these are the patients that do very poorly even with the transplant. I'm sure Dr. Laport can remark on that as well. So it's a little bit, I'm doing it a little bit differently, but the negative PET scan tells me that I'm in business. A positive PET scan, even after the second cycle, if you're going to change your therapy, please make sure that you have histologic confirmation, because they're all false positive PET scans.
So what will you change it to? I mean, if it's a bad
That's the problem. See, if it's positive, do I go on to be a cop? Or after the second cycle, if I still haven't had a major drop in the SUV score and I biopsy him, should I take that patient to transplant and not waste my time with a bunch of treatment that's not going to work? That's the conundrum. My personal bias is if I don't see a whole lot of drop after that second cycle, I got inherent drug resistance. If I proved it with a biopsy, and I would really want to go into something else, I would probably take that patient to salvage chemotherapy and a transplant with brentuximab. Well, if there are no more questions, I'd like to thank the panelists. I'd like to point out to everyone that we finished on time, in fact, a little early. Thank you.